Good evening, my dear friends and colleagues. Our topic today is membranoproliferative glomerulonephritis. This is our agenda. Membranoproliferative glomerulonephritis, from its name, it is divided in two parts. It's a descriptive term, membrano, reflecting thickening of the basement membrane, and proliferative, proliferation of cells. From its name, we can expect the pathology, the thickening of the basement membrane and proliferation of cells in the glomeruli. As we said, MPGN is a pathological pattern of glomerular injury resulting from subendothelial and mesangial deposition of immune complexes and or complement factors, as we will go inshallah to describe, associated with proliferation in the glomeruli. So again, there is thickening of the basement membrane associated with proliferation. Other names for MPGN is lobular, because it has a characteristic pattern of characteristic shape of being lobular in biopsy, and other famous name is mesangiocapillary. So it has a membranoproliferative or mesangiocapillary glomerulonephritis. What about the epidemiology? The MPGN is decreasing in developed countries. In developed countries, it is decreasing. Why? Due to better control of infectious diseases. As we will see that infections are a very common cause for MPGN. So in developed countries, MPGN is decreasing, but it remains common in low and middle income countries. The incidence is fewer than 1 to 2 cases per million population. From all cases of MPGN, only 4 to 5% of MPGN cases are due to C3 glomerulonephritis. So the incidence of C3 glomerulonephritis from MPGN is around 4 to 5, only 4 to 5% of all cases. Here, this is our common picture for the causes and prevalence of GN or diseases causing nephrotic syndrome. The common causes of nephrotic syndrome, as we all know in previous lectures, that are minimally changed focal segmental and membranous nephropathy with different incidence between populations and races. And as we see here, MPGN is not a common cause of nephrotic syndrome. It has a low incidence. The most common presentation for membranoproliferative GN or mesangiocapillary glomerulonephritis is a mixed nephrotic and nephritic presentation. So in most of the cases, we see nephrotic range proteinuria and nephritic element in the form of hematuria. So it is not a common presentation to be presented with pure nephrotic, but the most common presentation for MPGN is a mixed presentation, nephrotic and nephritic. What about the classification? The old classification or the traditional classification of MPGN depends on the ultrastructural characteristics on the electron microscopy, and the MPGN have been classified into type 1, type 2, and type 3. What are the differences? In type 1, it is characterized by the presence of deposits in the mesangium and subendothelium. I am highlighting the important note. In type 1, the deposits are in the subendothelial space, while in type 2, dense deposits are present, also referred in type 2 MPGN, also referred as dense deposit disease. The deposits are present in the mesangium and the intramembranous are present in intramembranous. So in type 1, subendothelial, type 2, intramembranous, and in type 3, the deposits are subendothelial, intramembranous, and characteristically in the subepithelial. So again, the traditional or old classification of MPGN depends on the site of the dense deposits. In type 1, they are present subendothelial space. In type 2, known as dense deposit disease, are present intramembranous. In type 3, characteristically it is present in the subepithelial space. However, depending on the immune fluorescence microscopy, MPGN have been classified according to the which deposits. That these deposits are due to immunoglobulin and complement, or these deposits are only formed of complement without immunoglobulin, or a third entity that these deposits that there is no immunoglobulin and complement. So the newer classification for MPGN depends on the specific type of each deposit. It is either due to immunoglobulin and complement, or it is only formed of complement, or there is no complement and no immunoglobulin. This is the newer or the newest classification for MPGN. This is very important. This newer classification, according to Mayo Clinic, divides MPGN into two broad pathogenic pathways: immune complex or monoclonal deposition with or without complement. So here there is immunoglobulin with or without complement, and the second type is complement deposition without immunoglobulin deposition. So in type 1, it is, or the newer classification, there is immunoglobulin with or without complement, or complement deposition without immunoglobulin. It will be better classified or better discussed here. This is the most important table that you should know about MPGN. If you are asked about MPGN, or if you are going to diagnose and manage a patient with MPGN in renal biopsy, if you're asking for a renal biopsy and the biopsy report come to you with membranoproliferative pattern, membranoproliferative glomerulonephritis pattern, or mesangiocapillary, this table is your reference. Again, the classification now, or the newest classification, depends on, it is either immune complex mediated according to the immune fluorescence. If it is immune complex mediated, there is immunoglobulin. If there is immunoglobulin, or there is complement only without immunoglobulin, or non-immunoglobulin, non-complement mediated. So the newest classification, or the new classification, depends according to immune fluorescence what causes the injury. It is either due to immunoglobulin, or it is due to complement, only complement, or non-immunoglobulin, non-complement, or it is idiopathic. Type. What are the causes for immune complex mediated MPGN? This is your differential diagnosis. This is your evaluation, how to reach your diagnosis when a patient comes to you with a biopsy report of MPGN. And the immune fluorescence shows immunoglobulin and complement, then you should think it might be due to infection, it might be due to autoimmune disease, it might be due to monoclonal immunoglobulin. This is very important. Regarding infection, the most common, I'm highlighting the most important, the most common infection causing MPGN are hepatitis C and hepatitis B. Viral infections can cause MPGN, bacterial and protozoal infections can cause, but the most common cause of MPGN is hepatitis C, then hepatitis B. Bacterial infections can cause in the form of common bacterial infections are infective endocarditis, infected ventriculoatrial shunt, visceral abscesses, leprosy, and meningitis. Malaria, schistosomiasis, mycoplasma, and leishmaniasis also can cause MPGN. All of these infections can cause MPGN, and we will discuss it later. What about autoimmune diseases? The most important is systemic lupus, Sjogren syndrome, and rheumatoid arthritis. Systemic lupus can present with membranoproliferative pattern in the form of combined class 3 plus 5 or combined 4 plus 5. Or immune complex mediated can be due to monoclonal immunoglobulin as a result of monoclonal gammopathies due to plasma cell or B cell disorder. So if we had an MPGN pattern in biopsy and immune fluorescence shows immunoglobulin and complement, we should think of infection, autoimmune disease, or monoclonal immunoglobulin. Infections, viral, bacterial, protozoa, the most important is viral. Autoimmune diseases, systemic lupus, Sjogren, and rheumatoid, or monoclonal gammopathies. But if we found in immune fluorescence that the deposits are only complement with negative immunoglobulin deposition, there is no immunoglobulin, it is only complement. These are C3 glomerulonephritis and dense deposit disease, and we will discuss it in a separate video or a separate lecture, inshallah. It might be these complement-mediated glomerulonephritis might be due to mutations in the regulatory protein, complement factor H and complement factor I, or antibodies to these regulatory proteins, C3 nephrotic factor, antibodies against complement factor H and complement factor I and complement factor P, or mutations in complement factors directly in C3 and CFB. MPGN might be due there is no complement in immune fluorescence. The result come to us the negative for immunoglobulin and negative for complement. No complement deposition or no immunoglobulin deposition in the biopsy. Here we should think of healing phase of TMAs, HUS and TTB, antiphospholipid syndromes, Boehm's syndrome, radiation nephritis, nephropathy, bone marrow transplantations, drugs associated with TMAs, sickle cell anemia, dysfibrinogenemias, and transplant glomerulopathy. The chronic forms of transplant glomerulopathy might present with a membranoproliferative pattern, negative for complement and negative for immunoglobulin. When all these conditions are not present, then we can diagnose this patient as having idiopathic MPGN. But I cannot diagnose a patient with idiopathic MPGN only after exclusion of these causes: infections, autoimmune disorders, monoclonal gammopathies, complement disorders, and these conditions. And I can exclude according to the result of the immune fluorescence. So when we are interpreting a biopsy, a light microscopy biopsy with MPGN, I should or I must ask for immune fluorescence staining to see if it is immune complex mediated with immunoglobulin plus complement, or due to only complement without immunoglobulin, or negative for complement and immunoglobulin. This is the most important table or the most important picture for you as regard MPGN. When MPGN is secondary to deposition of immune complexes as we just described, due to antigen antibody immune complexes that results from chronic, as we said, from chronic infections, autoimmune disorders, or paraproteinemias or monoclonal antibodies, on light microscopy there is proliferation. As we said, it is membranoproliferative. There is proliferation in the form of influx of neutrophils followed by mononuclear inflammations. And these injured mesangial cells and the endothelium cells produce a new basement membrane. Membrano, it is thickening of membrane. يبقى new basement membrane, from here comes the name membranoproliferative. Membranoproliferative. This will lead thickening of the basement membrane, and this will lead the characteristic, it is characteristic appearance, lobular appearance. Characteristic lobular appearance typical for MPGN. This lobular is very important. This term is characteristic for MPGN, a lobular appearance. Never to forget it. So in MPGN there is thickening of basement membrane, as we said, and there is proliferation of cells. These are the characteristic features for MPGN in biopsy. And these immune complex mediated are characterized by in immune fluorescence by the presence of immunoglobulins. As we said, it is characterized by the presence of immunoglobulins. These immunoglobulins are polyclonal in cases of infections and autoimmune disorders, and are monoclonal in cases of monoclonal deposits or paraproteinemias. These immunoglobulins are polyclonal in cases of infections and autoimmune disorders, and are monoclonal in cases of paraproteinemias. C3 complement is usually present. As we said, in cases of immune complex mediated, the deposition is usually in the form of immunoglobulin plus complement. And these immunoglobulins, in cases of infections and autoimmune disorders, are polyclonal, and in cases of monoclonal, they are monoclonal better. The complement mediated MPGN, which is characterized by the presence of in the biopsy of only complement with negative immunoglobulins, are much less common, and it is usually, as we describe, due to dysregulation of the complement alternative pathway, either due to mutations or antibodies to complement. As we said, the third entity, when there is absent immune complexes or absent immunoglobulins and complement, that results from in the form of chronic endothelial injury or chronic TMA. It might be there is also uncommon causes like cryofibrinogen glomerulopathy or lipoprotein glomerulopathy. Now let's discuss each one of them. We will start from the immune complex mediated, and the first one is infections that cause the immune complex mediated pattern. Here again, our algorithm, usually this patient come to us with a mixed pattern, nephrotic and nephritic. We ask it for a biopsy. Light microscopy shows membranoproliferative pattern or mesangiocapillary. We ask it for immune fluorescence, and the immune fluorescence come to us positive for immunoglobulin and positive for complement. What are the causes? Infections, autoimmune, and monoclonal gametes. We will start by infections. And infections might be viral, bacterial, and protozoal, but the most important is hepatitis C followed by hepatitis B. Again, this infection-associated MPGN, chronic viral infections such as we said, hepatitis C at first, then hepatitis B, are a very important causes of immune complex-mediated MPGN. Toll-like receptors, particularly toll-like receptor 3, might play a role in hepatitis C-related MPGN. Hepatitis B, the most common GN associated with hepatitis B is membranous, followed by MPGN, The pathology of hepatitis B related MPGN is likely to be related to trapping of the circulating immune complexes, but it also might be due to direct infection of the virus itself. So it might be due to trapping of the circulating immune complexes or due to direct infection by the virus. In cases of viral infections, the immune fluorescence, as we described, usually here there is immunoglobulin plus complement, but usually the immunoglobulin here is immunoglobulin IgM. The most common immunoglobulin in cases of viral infections is IgM. We can find also complement and kappa and lambda. On the other hand, in cases of bacterial infections, we found that the immunoglobulin present in the biopsy are usually IgG. Again, we hear in infection associated, it is immune complex mediated. We found immunoglobulin and complement, but in viral infections, the common immunoglobulin is IgM, while in bacterial infections, the common immunoglobulin is IgG. In electron microscopy, the deposits are present in mesangium and characteristically in the subendothelial. This is very important. Subendothelial. As we said, this will lead to a new GBM formation manifested by a very characteristic picture also known as double contouring of the basement membrane. So we have two characteristic terms, double contouring and lobular presentation or lobular shape of the glomerulus. These are the biopsy images for a case of hepatitis B, hepatitis C virus infection causing MPGN. Here for the first one, it is the light microscopy picture. As we see here, there is proliferation of cells. There is many cells here, many cells all over. So this is proliferation and the thickening of the basement membrane with the characteristic lobular appearance. Here. Again, lobular appearance. This is characteristic for MPGN. So lobular appearance with thickening of the basement membrane and proliferation of cells. This is characteristic for MPGN. Let's go for the immune fluorescence pictures. Here there is granular deposition for IgM, and C3. Again, in infection will cause immune complex mediated, immune complex in the form of immunoglobulin and complement. So in immune fluorescence, which is the basis of the new classification, there is positive staining for IgM and positive staining for complement. This is the electron microscopy picture showing with these black arrows the subendothelial deposits and double contouring subendothelial deposits, characteristic for immunoglobulins and type 1 MPGN. Now we will going to the next one. Again, MPGN, immune fluorescence, positive staining for immunoglobulin and complement. The second cause might be due to autoimmune disorders. The most important is systemic lupus, a combined classification, class 3 plus 5 or class 4 plus 5, Sjogren syndrome, and rheumatoid arthritis. And immunoglobulins here in infection are polyclonal, and in autoimmune disorders are polyclonal. Again, it is commonly seen in cases of autoimmune diseases, mostly with systemic lupus, rheumatoid, Sjogren, undifferentiated connective tissue disease, primary sclerosing cholangitis, and Graves' disease. What about Sjogren? Most of the cases of Sjogren with GN, 80% of cases from all cases of Sjogren which present with glomerulonephritis have type 2 cryoglobulinemia. We will discuss cryoglobulins later in a separate lecture. So in 80% of cases of Sjogren syndrome which present with glomerulonephritis, 80% of them present with cryoglobulins type 2 monoclonal. And Sjogren syndrome is considered one of the most common causes of non-hepatitis C cryoglobulinemia. The most important cause for cryoglobulin is hepatitis C, and if the patient is hepatitis C virus negative, one of the most important causes is Sjogren syndrome and paraproteinemias. We will discuss cryoglobulins in a separate lecture. On immune fluorescence, a full house pattern is usually common in cases of systemic lupus. It's very characteristic for systemic lupus, full house pattern. Positive staining for IgG, IgA, IgM, C1q, C3, kappa and lambda chains. This is what is called full house pattern. This full house pattern is commonly present in systemic lupus. IgM might be the dominant immunoglobulin in cases of rheumatoid arthritis and Sjogren. Again, in electron microscopy, the deposits are usually present in the subendothelial deposits, in the subendothelial space. And tubulo-reticular inclusion bodies are usually present in cases of lupus. Tubulo-reticular inclusions. Let's go for the next one. Immune complex mediated, immunoglobulin plus complement. The third cause is monoclonal immunoglobulins and paraproteinemias due to monoclonal gammopathy due to either plasma cell or B cell disorder. Monoclonal immunoglobulin associated MPGN, monoclonal gammopathies represent a heterogeneous spectrum of disorders characterized by what? Clonal proliferation. This is very important. Clonal proliferation of immunoglobulin producing B lymphocytes or plasma cell. The most important thing here, the most important pathogenesis is clonal proliferation of immunoglobulins. It's characterized by monoclonal immunoglobulin. Generally, in most of the cases, we might find a monoclonal immunoglobulin can be detected in blood or urine, which is called M band or M protein. M band, monoclonal band, can be detected by serum protein electrophoresis or urinary protein electrophoresis might be detected, but in some cases we might fail to reveal a monoclonal band. In some cases with monoclonal immunoglobulin associated MPGN, serum and urinary protein electrophoresis might be negative, and this does not exclude the diagnosis of monoclonal immunoglobulin diseases or associated diseases. They might be with negative protein electrophoresis either in serum and urine. M band or monoclonal band is not present in all cases. Does not present in all cases. This is very important because some of our colleagues think that if protein electrophoresis is negative, so this patient does not have any paraproteinemia. This is wrong. Protein electrophoresis is not 100% sensitive. It needs a comprehensive assessment in the form of serum and urinary protein electrophoresis, serum and urinary free light chain assay and ratio in the serum and urine. These combined investigations raise the sensitivity to detect any abnormality. So we should ask for these combined investigations: serum and urine protein electrophoresis, serum and urinary free light chain assay and ratio, kappa and lambda, to have a comprehensive assessment. These monoclonal immunoglobulins usually result in renal disease. They are usually present in case of lymphoma, multiple myeloma, or Waldenstrom macroglobulinemia. But if they are absent, if we didn't reach this diagnosis of a lymphoma or multiple myeloma, then it is diagnosed or named monoclonal gammopathy of renal significance. This is a very important term, monoclonal gammopathy. When we find there is a monoclonal proliferation or monoclonal immunoglobulins causing a renal problem or a renal injury, then it is defined as monoclonal gammopathy of renal significance that cause a renal problem. The glomerular diseases that might be caused by these monoclonal gammopathies of renal significance or due to monoclonal immunoglobulins in the form of proliferative glomerulonephritis with monoclonal immunoglobulin deposition, or in the form of amyloidosis, or fibrillary glomerulonephritis or immunotactide and monoclonal immunoglobulin deposition disease, light chain deposition disease or heavy chain deposition disease. So these are the glomerular diseases that can be presented in cases of paraproteinemia: proliferative glomerulonephritis or amyloidosis, fibrillary immunotactide, and light chain or heavy chain deposition disease. MPGN is a very common presentation, is a very common pattern of presentation of glomerular injury for these paraproteinemias. Immune fluorescence studies are very crucial to diagnose in the form of immunoglobulin deposition. As we said, there is immunoglobulin deposition, but it is monoclonal. This is the most important note. It is monoclonal, not polyclonal. There is immunoglobulin deposition, but it is monoclonal. How it is monoclonal? It is kappa or lambda, either kappa or lambda, not both. Kappa or lambda light chain restriction. This is how to know that it is monoclonal. The most common immunoglobulin here is IgG, usually the heavy chain of IgG. The deposition or in the dense deposits are in the subendothelial space. The most common subclass of IgG is IgG3. The most common subclass is IgG3. So again, in monoclonal immunoglobulin associated MPGN, in case of MPGN due to monoclonal immunoglobulins, the deposition is immunoglobulins in the immune fluorescence, and these immunoglobulins are monoclonal, either kappa or lambda, usually IgG, and the most common subclass is IgG3. In electron microscopy, the dense deposits are present in the subendothelial mesangium and subendothelial. In a recent study, almost all patients had a monoclonal or biclonal band on serum immune fixation studies. Almost all, but it is not, but in some cases it might be negative again. In some cases it might be again. Let's look for the bone marrow studies for 16 cases of monoclonal gammopathy of renal significance. Again, what is that term? These are monoclonal gammopathies or monoclonal immunoglobulins that cause a renal problem. So it is called monoclonal gammopathy of renal significance. And they took bone marrow studies from these 16 cases, which revealed 2 cases with multiple myeloma, 2 cases with CLL, 1 case of Waldenstrom, or its newer name is lymphoplasmacytic lymphoma, 3 cases of low-grade B-cell lymphoma, and 6 cases of multiple myeloma. So, all patients with MPGN with a monoclonal immunoglobulin deposition should be evaluated. This is very important. Should be evaluated for an underlying, very important in our evaluation and management of such patients, should be evaluated for an underlying plasma cell or B cell proliferative disorder in cases of monoclonal immunoglobulins in immune fluorescence. These are the biopsy images for a case of monoclonal immunoglobulin associated MPGN due to monoclonal immunoglobulin deposition. Let's look for this biopsy picture. Here is the light microscopy with periodic acid chief stain. Again, there is proliferation of cells. Look at the number of cells, and let's look for the thickening of the basement membrane and the lobular pattern of the glomerulus, characteristic pattern for MPGN. Let's look for the immune fluorescence, which is the most important part of our assessment for an MPGN case. Here there is a positive granular staining for immunoglobulin. We will found, of course, immunoglobulin staining positive. This immunoglobulin G. Here, positive for kappa light chain, negative for lambda. So this is monoclonal, positive for kappa and negative for lambda. Here there is positive staining for IgG3 subclass 3. As we said, it is the most common subclass. And here the electron microscopy showing subendothelial dense deposits. Subendothelial dense deposits, characteristic for MPGN type 1. Let's go for the next one, which is the complement mediated MPGN, C3 glomerulonephritis and dense deposit disease. Again, from our pathway case, light microscopy, MPGN pattern in light microscopy, immune fluorescence. There is positive complement, negative for immunoglobulin. Positive for complement deposition, but negative for immunoglobulin. It will be discussed in details in a separate lecture. It might be due to mutation in the regulatory proteins, or due to antibodies in the regulatory proteins, or mutation in some factors. C3 glomerulopathy, characterized by dominant C3 staining with minimal or no immunoglobulin staining in immune fluorescence. All of these dependent on the immune fluorescence staining for immunoglobulin and complement. It will be discussed later in a separate lecture, complement-mediated MPGN. The last one is that non-immunoglobulin, non-complement-mediated. In light microscopy, it is MPGN, but in immune fluorescence, it's negative for complement and negative for immunoglobulins. It might be due to, most importantly and most commonly, due to healing phase of HUS and TTP, or in case of antiphospholipid, dysfibrinogenemias, transplant glomerulopathies. There is also some uncommon causes of MPGN, like cryofibrinogen related MPGN, cryofibrinogen. Cryofibrinogenini is a rare disease that presents with an MPGN pattern. Let's look for the definition. How to diagnose cryofibrinogen. Cryofibrinogen is a cryoprecipitate that develops after refrigeration of plasma but not serum. This is very important. This is the differentiating point. Cryofibrinogen is a cryoprecipitate that there is precipitation after refrigeration of plasma but not serum. But when both serum and the plasma form a precipitate on refrigeration, the responsible proteins are cryoglobulins. This is very important. How to differentiate between cryoglobulins and the cryofibrinogen? Cryoglobulins cause precipitations on both serum and the plasma, but cryofibrinogens cause precipitation for plasma but not serum. Cryofibrinogen might be asymptomatic but might be associated with thromboembolic diseases, particularly affecting skin. These are the biopsy images for cryofibrinogenini or cryofibrinogen associated MPGN. Here is a picture of MPGN with H&E stain, very characteristic with the proliferation and lobular appearance. Here with the methenamine silver stain, same picture of MPGN but with Mason trichrome stain. Let's look for the electron microscopy. Here there is a randomly arranged subendothelial fibrillary deposits with tubular structure, with intraluminar tubular deposits. Here it's just more obvious. Tubular deposits with a large central pore with multiple layering. يبقى characterized by the presence of tubular deposits or tubular structures and fibrillary deposits. in electron microscopy. Also, another rare causes for MPGN is C4 glomerulopathy and collagen type 3 glomerulopathy. Here in C4 glomerulopathy, deposits are mainly C4, complement 4, with little or no immunoglobulin deposition or C3 deposition. It is mainly formed of complement 4. In the form of this glomerulopathy might be C4 complement 4 dense deposit disease and C4 glomerulonephritis, like in C3 dense deposit disease and C3 glomerulonephritis. It is the same here. May be caused by overactive lectin pathway of the complement. Usually the renal biopsy shows an MPGN pattern. Collagen type 3 glomerulopathy is a rare disorder characterized by a massive accumulation of atypical type 3 collagen fibrils in the mesangium and subendothelial space. Now let's talk about the evaluation of patient which comes in with a biopsy of MPGN. The evaluation or our main concern should be guided against the possible cause or the suspected cause, depending on the clinical presentation and biopsy finding. The standard workup includes, of course, a complement evaluation in the form of C3 and C4. When there is low C3 and low C4, this is usually more typical for a classic pathway activation in cases of immune complex mediated GN. When there is low C3 and low C4. But in case if there is low C3 and normal C4, this is usually present in abnormalities of the alternative pathway, like in cases of complement-mediated MPGN. Also for evaluation for cases, again to remember the table: immune complex mediated, complement mediated, non-immunoglobulin and non-complement mediated. And the immune complex mediated are usually infections, autoimmune and monoclonal, so we should exclude infection. The most important cause or the most important infections are viral infection. So in our evaluation, we should ask for a viral serology, hepatitis C virus antibodies, hepatitis B surface antigen, HIV antibodies, and also PCR for these viruses. Parasitic infections, we should ask for blood test for malaria, urine and stool test for schistosomiasis, and serology for schistosomiasis and leishmania. For bacterial infections, we can ask for blood cultures from catheter tip, imaging studies for deep abscesses, and transthoracic echocardiography to exclude infective endocarditis. Parasitic and viral and fungal infections should be only investigated when there is a suspicious, like a history of recent travel to endemic regions, prolonged fevers of unknown origin, or atypical pulmonary infiltrates. Autoimmune diseases are usually excluded by asking for tests like anti-nuclear antibody, anti-double-stranded. For Sjogren's syndrome, we should ask for anti-Ro, anti-La. For rheumatoid arthritis, we can ask for rheumatoid factor, anti-CCB, according to the cause. Regarding monoclonal gammopathies, as I have said before, we need a comprehensive assessment. We shouldn't depend on protein electrophoresis only. We should ask for protein electrophoresis in the serum and urine, and you should ask for serum and urinary immune fixation. We should ask for free light chain assays in the serum and urine and ratio. And of course, we can ask for bone marrow evaluation to detect if there is an underlying plasma cell disorder and or lymphoproliferative disorder. This is how to assess a patient with a suspected monoclonal gammopathy. This is very important. What about the KDIGO guidelines 2020 about the management of MPGN? Regarding the diagnosis, KDIGO said that we should search for the underlying cause because this is the most important. And these are the causes, as I am said in details: immune complex mediated, complement mediated, without immune complexes or complement, and idiopathic, as we said in our lecture. Immune complex mediated might be due to infection, autoimmune, or monoclonal immunoglobulin and fibrillary. Complement mediated C3 glomerulonephritis, C3 dense deposit disease, C4 glomerulonephritis, and C4 dense deposit disease, as we said before. And we said the cases or the conditions that might present with MPGN with a negative complement and negative immunoglobulin, and the most important are TMAs. And if we exclude all of these, we can diagnose our patient with idiopathic or primary MPGN. Patient with monoclonal immunoglobulin deposition, as I just said, should be screened for a hematological malignancy. In the form, we should ask for bone marrow aspirate. If no etiology is found for immunoglobulin immune complex mediated glomerulonephritis, we should evaluate or search for complement dysregulation. Evaluation of abnormalities of the alternative pathway of complement include these: functional assays, quantification of these complement components and regulators, measurement of activation, autoantibodies to these complement factors, genetic testing for these complement factors, plasma cell disorders in the form of serum free light chain, serum and urine electrophoresis and immune fixation, immune fluorescence, which is the most important part of our assessment of an MPGN case. Immune fluorescence for IgA, IgG, IgM, C1, C1q, C3, fibrinogen, kappa, and lambda staining C4D. We should search for in each biopsy presented with MPGN. We should rule out infection. Rule out infection, which is an important cause for MPGN. And the most common infection, viral, bacterial, and parasitic, and the most important are viruses, hepatitis C and B. We should evaluate for the presence of a monoclonal protein in a patient who present for the first time with a C3 glomerulopathy with an age over 50 years. So if a patient presented with C3 glomerulopathy over 50 years, we should search for monoclonal protein. What about treatment? We will start with the treatment of immune complex mediated GN. Immune complex mediated might be due to infection, might be due to autoimmune, might be due to monoclonal immunoglobulin. What to treat? The most important to reach a diagnosis, to reach a cause. It is usually a secondary cause, and treatment should be directed to the primary cause. Treatment here should be directed to the primary cause. If this MPGN is due to hepatitis C, we should treat hepatitis C. If it is due to hepatitis B, we should treat hepatitis B. If it is due to systemic lupus, we should treat for systemic lupus. If it is Sjogren, we should treat Sjogren. It is according to the cause. If it is due to monoclonal proteins, monoclonal gammopathy, we should treat the underlying disorder. This is the most important. If it is secondary, we should treat the primary cause. If it is indolent, if this patient is indolent, we can treat it with only supportive care, with only in some cases we can use immunosuppression. But the main part of our management is supportive. In cases of idiopathic MPGN with proteinuria less than 3.5 gram and normal GFR, we should manage with supportive therapy with RAS blockades, with ACE or ARBs. In case of idiopathic with proteinuria less than 3.5 gram and normal GFR, we can treat with ACE or ARBs. But in cases with idiopathic MPGN with nephrotic syndrome with proteinuria more than 3.5 gram with hypoalbuminemia, we can treat with steroids. In idiopathic MPGN with abnormal kidney function but without crescent, and there is active urinary sediment, so in the presence of abnormal kidney function, we should add steroids and immunosuppression. In case of RBGN, we should treat with high dose steroid and cyclophosphamide. In RBGN, steroids and cyclophosphamide. In cases with advanced cases with estimated GFR less than 30, we should treat with supportive care only, because there is extensive IFTA tubulointerstitial fibrosis, and you will not gain much benefit from using heavy immunosuppression. What about treatment of monoclonal immunoglobulin associated monoclonal gammopathies causing MPGN? Again, we should treat the cause. Treatment of monoclonal gammopathies causing MPGN is complex, usually in the form of conservative ACE or ARBs plus immunosuppressive therapy with the use of steroids alone or with alkylating agents, cyclophosphamide or chlorambucil. We can use thalidomide, bortezomib, and MMF. All of these have been tried with variable outcomes. So usually in case of monoclonal gammopathies causing renal impairment, monoclonal gammopathies of renal significance, conservative plus steroids, plus cyclophosphamide or chlorambucil, we might use thalidomide, bortezomib, MMF. Rituximab shows an encouraging results. Also, the treatment might be according to the type of the immunoglobulin. If the immunoglobulin is mainly IgM, monoclonal protein, we can suggest a regimen used to treat Waldenstrom, because Waldenstrom macroglobulinemia is due to IgM monoclonal gammopathies. We can treat like Waldenstrom in the form of rituximab 4 doses in a dose of 375 mg per square meter with or without steroids. So mainly depending on rituximab if the immunoglobulin is IgM. But if the monoclonal immunoglobulin is not IgM like IgG or IgA, we can use a regimen of bortezomib plus dexamethasone or bortezomib, cyclophosphamide, and dexamethasone, similar to the regimen used to treat multiple myeloma. Typically, patients are treated for at least 6 months and then we reassess. So we can treat patient according to the type of the immunoglobulin. If the monoclonal immunoglobulin is IgM, we can treat with rituximab. If it is non-IgM, we can treat with bortezomib, dexamethasone, and cyclophosphamide. Usually these patients are treated for at least 6 months and then we should reassess. In cases of C3 glomerulopathy, which we will discuss later in a separate video, these patients should be initially treated with MMF. The first line is MMF, and if MMF failed, they should be treated with eculizumab. The first line to treat C3 glomerulopathy is MMF, then eculizumab. Again, we reached the end of our lecture. Don't forget, the scenario is a patient coming to you with a presentation of a mixed nephrotic and nephritic, proteinuria usually more than 3 grams, and hematuria and impaired kidney function. In most of the cases is a mixed pattern, and you ask for a biopsy. In the light microscopy it shows membranoproliferative pattern, and then you should ask for the immune fluorescence. When the immune fluorescence come to you shows this, there is a staining, positive staining for immunoglobulin and complement, this is immune complex mediated. And the usual causes are infections, autoimmune disorders, and monoclonal immunoglobulin. If the immunoglobulin are polyclonal, kappa and lambda, it might be infections, and the most important is hepatitis C followed by hepatitis B. It might be due to bacterial infections and protozoal infections, or due to autoimmune disorders. Secondary to autoimmune disorders, the most important is lupus, Sjogren, and rheumatoid. And if it is exclusively kappa or lambda, it is a monoclonal immunoglobulin staining, and we should ask for protein electrophoresis serum and urine, free light chain serum and urine, and serum and urinary immune fixations, and we can ask for bone marrow aspirate to find if there is an underlying plasma cell or lymphoproliferative disorders. But if the biopsy coming to us with immune fluorescence staining only for complement, negative for immunoglobulin, this is called complement mediated MPGN. Usually it is due to C3 glomerulopathy in the form of C3 glomerulonephritis or C3 dense deposit disease. We'll discuss it later in detail. And if it is the MPGN, the immune fluorescence staining come to us with negative staining for complement and negative for immunoglobulin, this pattern might be present in case after HOS, TTP, antiphospholipid, and transplant glomerulopathies. Thank you, and please take care of yourself and your families. Ramadan Kareem for everyone. Thanks.